Morning and welcome to the Department of Medicine Grand Rounds here at University of Louisville. We are thrilled this morning to have a speaker from up the road at University of Cincinnati, Dr. Rachel Foote, who's an assistant professor and co-director of the post-COVID clinic. And she will be speaking about COVID and beyond, pulmonary manifestations of post-COVID syndrome, and her real introduction, as is our usual method, will be by our pulmonary division chief, longstanding, a great leader, Dr. Mohammed Saad.
Thank you, Dr. Williams. Good morning, everyone. It's my pleasure to introduce Dr. Rachel Foote from University of Cincinnati. Dr. Foote did a medical school in University of Toledo and did her residency and fellowship at University of Cincinnati, and subsequently stayed from 2018 as a faculty. And as all the people that come from University of Cincinnati that work with Dr. McCormick, of course, the area of interest for her is interstitial lung disease, mentored by a great scholar, Dr. McCormick, and did very well in her academic career, multiple publication and research, which is, again, not unusual for people who work with Dr. McCormick. So we are really excited really to have her talk to us today about the post-COVID, because again, this is very important topic for general pulmonologists and also for internal medicine, because we see them in our clinic. So when Dr. McCormick presented her name, I said, this is great. We would like for her to kind of come in and give us her insight into this. She's the co-director of the post-COVID clinic, University of Cincinnati, and had done a lot of work on this area. So I'm sure that this is going to be a very informative session. And I want to thank her again for taking time to talk to us. And again, thank you, Dr. Foote.
Thank you, Under, for that great introduction. I'm going to go ahead and share my screen. Can everybody see the presentation?
Yes, thanks.
Yes.
All right. And so, as was mentioned, I'm an assistant professor at University of Cincinnati in the Division of Pulmonary, Critical Care, and Sleep Medicine. And my interest as an outpatient have been, as of late, in post-COVID, and I'm a co-director of the post-COVID clinic. And along with ILD, interstitial lung disease, I've done a decent amount of that as an outpatient, but I also do critical care time both at UC and at the VA. So there will be a little bit of intermix of both of those topics. Conflicts of interest. I'm a sub-investigator and PI of a few industry-sponsored clinical trials that are not related to the topic of this talk. And today we're going to learn about the full spectrum of COVID-19, from the acute and the recovery, the long-term and the chronic phases of the disease. We're going to highlight some short-term and long-term morbidity of COVID, and summarize treatment options for long-term and chronic phases of post-COVID pulmonary disease. So to talk about pulmonary manifestations of post-COVID disease, it's hard to talk about that without at least introducing the topic of severe acute COVID infection, probably a topic that a lot of you have seen a lot of. So I don't want to dwell on it too much, but just to introduce, generally pneumonia is the biggest concern, with ARDS being predominant, requiring ventilator, which results in multi-system organ failure quite frequently. And then other organ-specific involvement can involve cardiomyopathy, myopericarditis, cardiac conduction abnormalities, acute kidney injuries and liver injuries, septic shock. We saw a decent amount of encephalopathy and psychosis not related to ICU delirium as well, and then a lot of thrombotic complications. In the early times of the pandemic, there was a lot of talk about acute COVID being different than non-COVID ARDS in the lay press, but also amongst the medical community. So I wanted to go through that a little bit. And to do that, really, we probably have to define ARDS. So it's, just review. It's an acute phase within the first 7 days. There's a significant hypoxemia involved with it, with a PaO2 to an FiO2 ratio of less than 300. And then you have to have non-cardiogenic bilateral opacities. This was a unfortunate pregnant lady that was taken care of and survived, but via ECMO, because there's only probably a few low functioning alveoli there on her CT scan. And so there was actually a study about how was acute COVID different than non-COVID ARDS. We still saw a lot of decreased compliance related to the degree of hypoxemia similar to non-COVID ARDS. We saw variable respiratory mechanics and recruitability between individuals, like we see in non-COVID ARDS, but we did have we were more likely to need rescue maneuvers for severe hypoxemia, such as proning, paralysis, and inhaled vasodilators. And we were more likely to have a prolonged duration of ventilation compared to non-COVID ARDS, looking at 13.5 to 18 days mean. Mortality-wise, there actually was not a difference between COVID and non-COVID ARDS, but there was a significantly slower time to vent liberation after adjusting for age, sex, and nursing home residents. Looking at histopathology from the autopsies, we saw diffuse alveolar damage, which is the pattern that you see for non-COVID ARDS, but there was more vascular, microvascular, macrovascular thrombosis, and a more severe endovascular injury compared to non-COVID ARDS. And patients who died 30 to 35 days after their initial infection, we saw more organizing pneumonia and fibrosis, which we'll talk about a little bit later. And then patients who survived and had persistent ILD who underwent other types of lung biopsies also saw that same organizing pneumonia and fibrotic pattern. So it's not surprising to say that patients with severe COVID or COVID pneumonia are more likely to have pulmonary consequences long-term, such as pulmonary fibrosis, and they are also more likely to have persistent diffusion defects in radiographic abnormalities. This was another patient cared for at UC who also survived, but had a very long hospital course. So I do want to go through a couple case studies just to go through the recovery of these patients more than anything. I think a lot of times we touch on one part of these patients' experiences in the healthcare system, but we don't get the full picture. So this patient was a clinic patient of mine who I happened to see in the hospital as well prior to him coming to the clinic. He's a 59-year-old male with a history of obstructive sleep apnea and psoriatic arthritis on Humira. He tested positive for COVID back in March of 2021, and then presented about a week and a half later with acute hypoxemic respiratory failure, was intubated, required a lot of those rescue maneuvers, and then was still, despite that, persistently hypoxemic and required cannulation with VV ECMO in early April. He had a lot of complications, superinfections, and it required a tracheostomy. He failed weaning trials from ECMO and eventually was able to be removed from ECMO 2 months later. So this patient was on ECMO for 2 months, finally decannulated and discharged to an LTAC a couple weeks after that. At the LTAC, another month before he was able to be weaned from the ventilator, and then decannulated a couple weeks later. At time of discharge from the LTAC, he required 3 to 5 liters of oxygen, still had a lot of exertional hypoxemia and cough, and was discharged home eventually on 2 liters. I saw him another 2 months after that in clinic, requiring 2 liters of oxygen. He was complaining at that time of persistent brain fog, dyspnea, cough, focal numbness, and restless legs, which ended up being a severe iron deficiency. But he walked into the clinic. These are some of his images. So this is initial CT when he was requiring ECMO with very dense infiltrates and ARDS. And then as these opacities evolve when he's weaning from the ventilator, we see a more typical pattern of this subpleural sparing here. And then as he is at home now, and pretty much what his CT still looks like to this day. One more case. This was another unfortunate gentleman, 43-year-old soccer player who developed COVID and was extubated on day 10. He was a semi-professional soccer player, so in very good shape. He had a cardiac arrest, Then achieved return of spontaneous circulation after 12 minutes. He had bilateral tension pneumothoraces, which were the etiology of his arrest, and he did recover neurologically, but then had a lot of complications related to his pleural spaces, required multiple chest tubes. This arrow is pointing out this chest tube that's not draining this space very well here. It ended up required another chest tube. This is a CT scan that's closer to his hospital discharge, where he still has quite a bit of reticular change and ground glass. And this is as an outpatient where he's now working out 5 days a week, but he still has quite a bit of abnormalities on his CT scan. So post-COVID syndrome is really not well defined or delineated. It's, I guess, defined now, but not well delineated. There are patients that come with persistent symptoms who have had experiences like this in the ICU. And then there's patients who had either no symptoms or very minimal symptoms when they had acute COVID. And post-COVID syndrome, to this day at least, includes all of these patients. And the terminology is variable depending on what literature you read, but includes post-COVID conditions, long haulers, long COVID, post-acute sequelae of COVID-19 or PASC, and the term in favor kind of depends on the week, to be honest. The presence of symptoms, it is defined by the presence of symptoms, again, depending on what literature you're reading, from 4 to 12 weeks. But the WHO defines it as 3 months after the COVID infection, and it doesn't even define that you have to have a definite COVID infection, but a probable COVID infection. And the symptoms have to last at least 2 months and cannot be explained by an alternative diagnosis. That, I think, is important. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but there are others, and the symptoms didn't necessarily need to be onset with the acute COVID infection. They can then onset a week or two later, and they can fluctuate or relapse over time. And so I bring this up because, as you can see, a lot of the patients that I kind of went through their cases earlier, they have a lot of persistent organ dysfunction. And there is an entity called post-ICU syndrome that's well accepted now. Patients who had a significant ICU stay who have related organ damage from the acute phase of their process. And this is, in these patients, likely due to viral infection or inflammatory response related to their ICU stay. And I think that, in my mind anyways, I delineate those patients from patients who did not have such an acute or severe presentation, but still have very significant symptoms that inhibits their daily life. And those I kind of loop into more of a post-COVID syndrome rather than a post-ICU syndrome. Talk a little bit about post-ICU syndrome. Again, it's a well-recognized entity and includes new or worsening abnormalities in physical, cognitive, and psychiatric domains after a critical illness. The pathophysiology is multifactorial and been proposed to involve microvascular ischemia and injury, immobility, and other metabolic alterations during critical illness. And this data is from pre-COVID, but we do know that lung function does tend to recover for the most part post-ARDS. These patients never had a PFT before they had ARDS, but they recovered to near normal of their peers at 12 months, with the exception of the diffusion, which is slightly low. So going through another case to kind of transition to the outpatient world now. This patient's name, her initials actually are UC. She's a 55-year-old female. She has stage 2 endometrial adenocarcinoma and had radiation therapy in 2019. She has rheumatoid arthritis. She's a former 30-pack year smoker, and she has a history of asthma, bronchitis, and diabetes. She presents to the post-COVID clinic. Her initial admission was April 15th. She had cough, shortness of breath, and required OptiFlow for many weeks on the inpatient side. At the time that she was being seen, the treatment du jour was Decadron, convalescent plasma, tocilizumab, and monoclonal antibodies, which she received. And now she's coming in with significant post-COVID symptoms, still desaturating to the high 70s. This was in September of that same year, with exertion, complaining of weakness and loss of sensation in her legs. And she's only really able to walk to the next room, the bathroom or the kitchen, and not able to do much else. And she has still a dry, non-productive cough. At home, she's been using an incentive parameter and a flutter valve a cappella without a lot of benefit, and just started physical therapy. And she had a steroid course that was held for swelling. So they had attempted to treat her with steroids later on in her course, and she was not able to tolerate it. And she had, it has been, her methotrexate for rheumatoid arthritis has been on hold since she had her acute COVID infection. These are some of her imaging. So during her acute presentation, she has a lot of ground glass here and some more areas of more dense consolidation, but certainly a multifocal picture. And now more, a little bit of architectural distortion and some reticular change. And this is to compare a previous CT that she had in November of 2019, where she has a pretty normal CT. Some might argue it's not completely normal, but this was an abdomen pelvis and not timed with breathing. So I wanted to go into some definitions before we kind of dive more into some of the post-COVID findings on lung disease. Interstitial lung disease is a broad term that includes various diffuse parenchymal lung diseases. And as far as pulmonary fibrosis goes, it's generally thought to be an end stage of an interstitial lung disease, but characterized by impaired reconstruction of damaged alveolar epithelium, persistence of fibroblasts, and excessive deposition of collagen, and destruction of the normal lung architecture. There are proponents, again, who refer to fibrosis as an irreversible end state. And thus fibrosis should not really be applied to these abnormalities that we see in cases of post-viral pulmonary fibrosis, because these changes can get better over time. But others argue that fibrosis can be considered a reversible process, and the term reversible pulmonary fibrosis is used sometimes in the literature. And then other authors have classified specifically post-COVID pulmonary fibrosis radiologically based on extensive and persistent fibrotic changes that include parenchymal bands, irregular interfaces, and reticular opacities and retraction bronchiectasis that may or may not have honeycombing. So who's at risk for this development of fibrosis? The radiographic or histologic pulmonary fibrosis on discharge and early follow-up occurs in 33 to 53% of patients hospitalized with COVID pneumonia, which is a fairly large number. And some of that Wuhan data from the really, really early time, it was 61% of patients who were there longer, so greater than 3 weeks. So the longer you're inpatient with COVID, the more likely you are to have COVID fibrosis. Age, disease severity, and ICU length of stay, along with duration of mechanical ventilation and smoking, is associated with fibrosis. And other studies and also implicated BMI, the presence of fever, and the highest procalcitonin as risk factors for persistent pulmonary fibrosis. I'm going to talk a little bit about telomeres because they're kind of a hot topic in interstitial lung disease, but I wanted to give a brief background on telomeres, and they're a repetitive nucleotide sequence that cap linear chromosomes and limit progressive chromosomal shortening during cell replication. We know that regardless of the ILD phenotype, individuals with short telomeres or a known telomere-related mutation have more rapid disease progression and a shorter lung transplant-free survival. So knowing this information, there was a study on COVID-induced fibrosis, and they looked at patients who, after having COVID, had a fibrotic-like pattern versus a non-fibrotic pattern. And the patients with the shorter telomeres, age-adjusted, because telomeres do get shorter as we age, but age-adjusted telomere length was associated with more likelihood of having a fibrotic pattern. So, and a pretty linear relationship. Additionally, SOFA score was also linearly associated, being a higher SOFA score, the more likely you were to have a fibrotic-like pattern. So organizing pneumonia, again, going into some definitions here first, but it's a histologic term characterized by patchy filling of alveoli and bronchioles by loose plugs of connective tissue known as Massoon bodies. Commonly, we think of COP or cryptogenic organizing pneumonia, but I would argue that probably more common is a secondary organizing pneumonia, especially after COVID. It's very common to see a secondary organizing pneumonia from COVID. And radiographically tends to look like ground glass opacities or consolidation that we do usually see more subpleural sparing. And it's a peribronchosvascular distribution, but can present sometimes as large nodules or masses as well. There's a study in the American Thoracic Society talking about post-COVID organizing pneumonia. And they looked at patients who had persistent symptoms and radiographic abnormalities 6 weeks after admission for COVID pneumonia. And they were discussed at a multidisciplinary ILD conference. And the majority of them had an organizing pneumonia pattern radiographically. These patients were not biopsied. This was not a confirmed organizing pneumonia by histopathology, but radiographically consistent. And then the multidisciplinary conference recommended that these patients receive corticosteroids based on, risk factors and what it was going to, what other comorbidities they had. And then they followed them in an observational study. These patients were given a maximum dose of 0.5 mg per kg of prednisolone and then weaned over 3 weeks. So they found that these patients' pulmonary function tests improved significantly. Basically, all measures of their pulmonary function test improved. There's a limitation to the study, right? It's an observational study. It's not a randomized controlled trial. The pattern is not biopsy proven. And we don't exactly know the natural history of organizing pneumonia that's post-COVID related without treating it. But drawing from other coronaviruses, it's likely that these patients would be left with a permanent fibrotic change in functional deficits if not treated. Looking at other types of ARDS, we don't typically see organizing pneumonia, a secondary organizing pneumonia after their infection or whatever was the etiology of their ARDS. And then steroids generally, though, are the first line of treatment for other types of organizing pneumonia as well. So that's kind of where some of the basis for the study came from. So looking now at some of the current COVID data, because I think everyone's kind of tired of hearing about COVID, at least acute COVID, and the cases and the deaths and hospitalization trends. This is all from March, so last month, are all downtrending. But if we look at wastewater surveillance, there's probably still a pretty high burden of disease, at least subclinical. Some sites are reporting wastewater data that are seeing highest levels of SARS-CoV-2 since December 1st of 2021. So it's still out there. We probably aren't testing for it. And we definitely aren't seeing the severity of illness and the severity of disease that we were seeing in the initial parts of the pandemic. But that is relevant because that still does not rule out these patients getting long COVID. And there's just probably still a lot of active COVID out there that's not being treated, not being tested for, but that doesn't mean these patients won't get long COVID. So I wanted to, again, transition to this second group of people who I kind of put in the hat more of post-COVID syndrome or long haulers or long COVID, who have initially a mild disease, may or may not have been even admitted to the hospital, mostly not. But they have persistent symptoms to the point where they aren't able to work sometimes, or they have a significant impact on their life. So one patient I wanted to kind of go through a case, Miss NK. She's a college athlete and she doesn't have any significant past medical history. She's, I didn't put her age in here, but she's 22. She doesn't smoke or vape. And she had COVID at the end of September of 2020. She had some fatigue and fever and chest pain during her acute infection. She never had pneumonia. She was never hospitalized. And then her chest came back. in 2020, and she feels more December 2020. She feels more dyspneic still than usual at practice. She's still easily fatigued, and she's still more tachycardic than usual with exercise. And that's actually documented because she's a college athlete. She wears a monitor with exercise, and she's significantly more tachycardic than her peers. So I was curious of who would do, what workup people would do on this patient. And this isn't really set up for like an audience response, but if anyone's brave and they want to put something in the chat or unmute, what people would do for an initial workup for this patient.
Well, of course, thinking, I know this is a pulmonary talk, but the first thing you'd be concerned about with the tachycardia is that she, like many athletes, developed myocarditis, and even with chest discomfort, that would be some pericarditis as well, because they tend to go together. Yeah,
and I should mention that my co-director in the post-COVID clinic is Dr. Richard Becker, who is a cardiologist and did see this patient as well. And so we kind of worked together on a lot of these patients to discuss what's appropriate workup for them. From a pulmonary side, I guess I'll start there and say that from a pulmonary side, I usually will get a chest x-ray and a PFT on everybody. And that's just because I don't want to miss post-COVID pulmonary disease. Definitively. And so, and I have started adding a MIP and a MEP, or mean inspiratory pressure, mean expiratory pressure, looking for diaphragmatic or neuromuscular weakness as well. We'll talk about kind of why, but then if the PFT is abnormal, I'll generally get a CT chest with expiratory views and some kind of low hanging fruit, B12 thyroid, CBC, and a renal panel on just about everybody. Because those are kind of things that are treatable and fixable, and I've caught. So this particular lady, she got a CTPA and a VQ scan, which were negative. She also got a cardiac MRI, speaking of the myocarditis, which was normal. And then her pulmonary function test revealed some restriction and some not technically abnormal MIPs and MEPs, but given her age and the fact that she's a college athlete, I thought were quite notable that her MIPs and MEPs were on the lower end with her restriction. So I treated her as if she was having diaphragmatic weakness, and we'll talk about that ways that I treat that in a little bit later. So just going over some of these patients with long COVID and what we see with them, or post-COVID syndromes, that you'll have to excuse, I interchange terms just like essentially everyone throughout my talks too, but this was a VA patient population, quite a large patient population, and they divided patients into those who were hospitalized and those non-hospitalized, and looking at the non-hospitalized cohort. So presumably patients who were less sick, 73,000 patients who were COVID positive and survived at least the first 30 days, they still saw an increased risk of death, increased incidence and frequency of requiring outpatient care at 6 months, and the most common symptom that didn't require hospitalization was respiratory. So other common findings, though, were neurocognitive, brain fog, headaches, and this attributed to a 10-year aging in cognitive function for the patients who were tested with their cognitive function was tested. They had a lot of mental health problems. They had new metabolic disorders that were diagnosed, dyslipidemia, diabetes and obesity, new cardiovascular diseases diagnosed, incident hypertension, coronary disease, cardiac dysrhythmias and cardiomyopathies. And then a lot of them had malaise, fatigue, and muscle weakness. An article from JAMA looking at predictors of post-COVID conditions This found that sex in general, female sex was more significantly associated with the risk of post-COVID syndrome. And older patients. So when they divided into 3 age groups, the 40 to 69 cohort and greater than 70 cohort were both more likely than the patients under 40 years to have post-COVID syndrome. And then obesity was found to be significantly associated with post-COVID syndrome, along with asthma, hospitalization, and immunosuppression. This was from an article published in Nature. We're estimating about 65 million individuals around the world have long COVID, and saying that that's probably a pretty conservative estimate, considering that it's thought to be about 10% of patients who were ever infected with COVID. And there's, 651 million at that time, and more now, probably, cases worldwide. And the number is probably a lot higher with a lot of undocumented cases. It's estimated that 10 to 30% of non-hospitalized cases of COVID have long COVID, and 50 to 70% of hospitalized cases have long COVID, along with 10 to 12% of vaccinated cases. So that does bring up the point that vaccination is probably somewhat protective for long COVID. So there are a lot of hypothesized mechanisms of long COVID pathogenesis. I will say that probably not everybody is the same, and not everyone's mechanism is probably the same, having seen a lot of these patients. But this is again from that Nature article, that the thoughts of immune dysregulation being the etiology with or without reactivation of underlying pathogens, including EBV and herpes viruses, gut microbiome or virome involvement, autoimmunity and immune priming, and then microvascular disease and clotting, along with dysfunctional neurologic signaling. And so, speaking of which, vaccination we think does help reduce the risk of long COVID. Looking at an EMR review of over 1 million patients, it's a decreased incident disease after COVID of hypertension, thyroid disease, and diabetes for patients who were vaccinated. And then a decrease of new symptom onset after COVID, with decreased amount of respiratory symptoms, fatigues, body aches, headaches, and diarrhea. But it is not completely protective. And so I wanted to briefly just put a plug in here that, a lot of these patients, especially earlier in the pandemic, were kind of dismissed. And I still see a good number of patients that come to me who have been dismissed by other doctors. And we have kind of a long history of not exactly knowing what the other potential etiologies of other post-viral syndromes are. And so it's difficult to go through a lot of these symptoms, and easy to say that these are psychologic or pretentorial. So there's enough evidence that these patients, that they have real disease, they have real symptoms, and because this was a pandemic, I think that kind of brought that to light, because there's just too many people with these symptoms to ignore. And so I would just urge everyone that just thinking that this is all from anxiety and depression is probably not the best way to go about handling these patients. To keep your differential broad as well, and avoid anchoring. I've seen quite a few patients who have other diagnoses that are not necessarily even related to COVID: Parkinson's, severe hypokalemia from B12 repletion, just in pregnancy, other diagnoses. So just labeling them as post-COVID and being, you need to make sure that there's some workup done at least first to go through and make sure there's nothing else we're missing, because not everything that follows COVID is necessarily long COVID. So going through some of the other post-COVID pulmonary conditions besides what we've talked about, worsening of some underlying pulmonary disease that in some patients hasn't always been diagnosed before. I've had patients who did have evidence of prior interstitial lung disease on their CT scans before coming and before having COVID, and patients who probably had COPD before having COVID as well, based on some of their symptoms before COVID. And we do know that other viruses can drop people's pulmonary function tests, the degree of obstruction that we see, and in COPD, and then they never quite recover after that viral infection. I think that probably happens with COVID as well. Other things are viral bronchiolitis, so something that we think more of in kids and babies, respiratory RSV related, but I've seen this in adults in COVID. They have a pretty normal looking CT scan on inspiration, but on expiration, they have a lot of lobular air trapping. And then upper airway disease, so patients who were intubated, this is not an uncommon finding, that you'll see subglottic stenosis. This is a patient with subglottic stenosis, and this is her vocal cords here, and you see some narrowing in the trachea. In patients who were intubated, you'll see like granulation tissue in the prior areas of where the endotracheal balloon sat. This patient actually was never intubated and had subglottic stenosis secondary to COVID, presumably, and underwent a dilation and felt much better afterwards. And then I've also seen some vocal cord paralysis related to COVID as well. And then we talked a lot about other persistent post-COVID imaging abnormalities. So a lot of things can contribute to post-COVID respiratory symptoms. This was taken from the Annals of Thoracic Medicine, but I actually added a couple things, and probably more than one in a lot of patients, right? Especially these are tend to be people who had more severe COVID, but in patients who had less severe COVID, probably some diaphragmatic dysfunction, maybe damage to stretch receptors, and upper airway disease, always something to consider too. Cough after COVID. This is looking at all of the studies essentially that have been done in post-COVID cough, looking at acute cough versus more persistent cough. But it's probably in the 20 to 40% range. And then in SARS-CoV-2 can induce cough potentially via neuroinflammatory and neuroimmune mechanisms. It's thought to be more of a neuroinflammatory response induced by the virus rather than direct invasion of the virus into the neurons. But also important to rule out other pulmonary disease or asthma as a cause of post-COVID cough. And so treatment-wise, I generally try to reserve the opioids for the last resort, for inhibiting cough reflex. Our gabapentin can be helpful. Tiotropium, which the brand name is Spiriva, is for, can reduce cough reflex sensitivity in acute viral cough. And then you can refer patients to speech and language pathology with chronic cough. There are some speech and language pathologists who specialize in that and work with patients with chronic cough. And then, other usual suspects, like making sure they don't have GERD and they're not on an ACE inhibitor and they don't have postnasal drip and other causes of airway inflammation. So looking specifically at patients who have normal PFTs but still have exertional dyspnea, these are some proposed mechanisms behind their symptoms still. So hyperventilation being one, dysautonomia, neuroinflammation, including neuromuscular weakness, the stretch receptors, and including brainstem dysfunction and inducing either hyperventilation or dysfunctional breathing, deconditioning, and then cardiac causes as well. Obviously important not to forget about. So specifically looking at the neuroinflammation that can cause some diaphragmatic dysfunction, there are multiple case reports of diaphragmatic weakness following COVID. One study that confirms these cases by ultrasound thickening fraction, and thought to be involvement of the peripheral nervous system by COVID. Again, believed to be more of a neuroinflammatory etiology rather than direct nervous system infection. This is based on some CSF studies without a SARS-CoV-2 antigen, and along with, there's also been evidence of T-cell infiltration of the olfactory bulb. And these are 3 of my patients who had low MIPS and MEPS and diaphragmatic weakness, PFTs. Other potential etiologies, hyperventilation or dysfunctional breathing, we have seen exercise hyperventilation being defined as inappropriate alveolar ventilation. 3 studies in the literature kind of confirm that you can see this on CPET or cardiopulmonary exercise test, minute ventilation to carbon dioxide production ratio that's elevated. And then they have some presence of respiratory alveolosis on end exertion ABG, and some variability in their ventilation during the CPET, which is consistent with dysfunctional breathing. There's an additional study that doesn't use CPET that uses a hyperventilation challenge and a low resting PaCO2 along with this questionnaire about hyperventilation with associating it with long COVID or post-COVID syndrome. It's not really known the mechanism of hyperventilation syndromes in general, but it kind of coexists with organic disease. So patients who have acute PE, they are known to hyperventilate. Pneumonia or chronic ILD also, they can hyperventilate even though they have organic disease, they're ventilating beyond what their needs are essentially. And then there's some questions about, is there brainstem involvement that's potentially causing this? There's a postmortem study showing pronounced neuroinflammatory changes in the brainstem being the most common finding after COVID. Some patients have dysautonomia or POTS. It can cause the typical symptoms of dizziness, orthostasis, and palpitations after COVID, and can be confirmed with a tilt table test. I'm not a POTS expert, so I'll just go briefly into some of the non-pharmacologic treatments, which can include like hydration, compression stockings, abdominal binders, reducing carb intakes, and increasing salt intakes. And there are some pharmacologic treatments, but would leave those to the POTS experts. And looking at CPET data, specifically other CPET data, there's one specific study that I wanted to kind of point out that shows some circulatory impairment. And this study looked specifically at CPET with a cardiac MRI. So they have the patients in the supine position undergoing a cardiac MRI while they are exercising, as compared to a traditional CPET with an upright cycle ergometer. So this study compared 3 groups of patients, patients without a history of COVID, patients with a history of COVID without residual symptoms, and patients with a history of COVID and with residual symptoms. And they found that the patients with the residual symptom group had a significantly lower VO2 max than the other groups, and that this was due to a lower peak cardiac output resulting from failure to augment stroke volume. And so these authors propose that this is more of secondary to impaired preload potentially related to dysautonomia, but that's not quite proven in this CPET study. Again, probably still a subset of patients. It doesn't encompass everybody who still has persistent dyspnea after COVID with a normal PFT. How do we manage these patients? So some of the hyperventilation syndromes, beta blockers, for other non-COVID etiologies have been used successful. I can't say that I've had a lot of success using them for post-COVID indications for hyperventilation syndromes. Diagnosing and treating underlying anxiety and depression is obviously important. And then, POTS, if that's a concern, potentially considering the methods of volume expansion or sending them to a POTS expert. Yoga breathing, I talk with a lot of my patients about, and other dyspnea breathing exercises, because I don't really have, a pill or some magic medication that's evidence-based at this time to treat these patients. And then incentive spirometry and pulmonary rehab are some of the other methods that I've used. Ending, I wanted to thank Dr. Becker, who's my co-director in the post-COVID clinic, Dr. McCormick, that we've already kind of mentioned is the chair of pulmonary here at UC, and one of my mentors, the patients that allow me to care for them and my own family as well. And those are my three little kiddos, seeing Scuba Santa in Cincinnati last Christmas. And I open it up for questions and comments.
Indeed, please. Thank you so very much, Dr. Mohammed Saad. I'm going to take over the question and answer, please. I think he's on.
Yeah,
mute.
hi. I wanted to ask you about the structure of the clinic, because we tried to have something similar here, and I'm wondering about the staffing support and hospital support for this clinic, because this is a very important area that we're going to be seeing for a long time to come. So can you share this with us?
Yeah, initially we got some support from the local government with a grant to start the clinic up. And it's Dr. Becker and I are the two co-directors. And so we, tend to see a lot of the incoming patients and kind of sort through them about who needs to go see other subspecialties. And then we also have some rheumatology involvement and immunology involvement as well more recently. We had a neurologist, but he has since left, but I think neurology involvement would be awesome too. But it's been difficult to get support past that initial grant. I would argue that it is a money, generating venture, because we bring in a lot of patients who probably otherwise would just be seeing community providers, and we bring them into the academic setting and refer them to other specialists. So we've tried to use that argument to continue to function, but it has been difficult because but Dr. Becker and I both have other responsibilities, other things that we do, and we can only see so many patients. So we have a large backlog, admittedly, too, of patients that are trying to get into the clinic. But the design of the clinic was for primary care doctors to send patients who they thought had persistent post-COVID symptoms to our clinic after they had kind of an initial workup through the primary care doctor. That wasn't always how patients came to us, because they heard about us through other means or something like that, but that was the initial design.
Thank you.
If I can ask, one of the issues that we've struggled with in cardiology is getting people appropriately sent to cardiac rehab. And I would imagine, particularly after we're very, very interested in your case of the athlete with the diaphragmatic dysfunction, that seems like that's something that pulmonary rehab would really be helpful for. Have you seen an uptick in pulmonary rehab centers and volume and referrals in response to long COVID?
Yeah, I mean, yes, definitely. And I think like you said, we have found more success with these patients with pulmonary rehab than cardiac rehab, because I think just the way that the rehab is designed for pulmonary patients, it's more for trying to live with their disease a lot of the times and learn how to make the best out of what they have, which is unfortunately a lot of times what these patients with long COVID have, is trying to deal with chronic disease more than get over an acute event necessarily. So we've had success with our pulmonary rehab referrals, and generally to get it approved through a lot of insurance, we have to have some other diagnosis besides just post-COVID conditions, that ICD-10 code, but usually you can find something else to add to it for an indication for pulmonary rehab.
Okay. Thank you, Dr. Fudd. Anyone else want to unmute and ask a question? We have a couple minutes left.
Here. All right. I actually have a question from in the chat. Is from Dr. James Bradley. He's one of our pulmonary fellows here. He wanted to know, he said, I had a question regarding some of your ILD patients and other patients who are on immunosuppression. When these patients get COVID, do you decrease their immunosuppression to allow them to clear the virus? And if so, do you find that this helps in clearing their symptoms or help to prevent long COVID in this patient population? Any thoughts on how you may determine how long these patients' immunosuppression should be lowered?
Yeah, that is a tricky question. So when patients get acute COVID and they tell me that they've been diagnosed with COVID and they're on immune suppression for other indications for ILD, I will hold, usually, if it's CellCept or Immuron or something like that, I will hold that for not a super long period of time, 1 to 2 weeks, again, to allow viral clearance and make sure they're recovering. And is, given that they aren't hospitalized in the ICU and that sort of thing, but at home, I will hold it. But it becomes difficult because how much of COVID, pneumonia and pneumonitis is because of the virus and how much is because of immune dysregulation and the immune response. So it's a hard question. I think it's on a case by case basis of how long you hold it, but a lot of times I will be the one restarting their immune suppression in these patients who, not personally, but telling them to restart their immune suppression for other reasons in these post-COVID clinics who are on it for, connective tissue disease or something like that, because people are afraid to restart their immune suppression.
And I had one more question in the chat area. This is from Dr. Satya Krishnasamy in our endocrinology division. Said a great overview, specifically long COVID and POTS. She says we have some patients asking about long COVID disabilities. Do you have any thoughts on that?
Yeah, I have done a decent amount of disability paperwork for these patients. I actually gave a talk to one of the medical directors for some of these companies that do disabilities. It's, they want to see something more than brain fog. I will say they want to see some sort of objective finding of abnormalities to qualify for disability. And so usually I have to try and find something to get them qualified for disability, because a lot of these patients are disabled, and hopefully not long term, but sometimes that's true. As far as getting them approved for disability, usually they have to have some sort of objective abnormality on testing, generally.
All right, that was okay. Doctor, have another chat question. This is Dr. Scott Hannon from our infectious diseases division. It says, Dr. Foote, you mentioned the pulmonary workup that you would typically order initially, and noted that faculty from immunology are involved in your clinic. Could you please comment on the basic immunologic workup?
Oh, well, I kind of leave it to him. I will say that if people have, I kind of direct more towards what some of their symptoms are. So some people have more, I wouldn't say connective tissue disease findings, but more things that point me in that direction. And those people, I will do a little bit of an autoimmune workup, which, is kind of an ANA and rheumatoid factor and that sort of cursory autoimmune workup. But, the details of the immunologic workup, I wouldn't comment on.
Okay.
All right, one more. This is from one of our community doctors, Dr. Philip May. He would like to know, would you please comment on the relationship of would you please comment on the relationship of a patient's pre-COVID level of physical exercise and post-COVID complications?
I can't say that I've necessarily seen an association. Like I gave the example of the college athlete. I have some patients who are super active before COVID, and those are the ones that tend to seek our clinic, I will say, because they are significantly deconditioned, not just deconditioned, but they just cannot do anything. And they are really active, high functioning people like physicians, lawyers, people who just cannot function anymore. And I don't think there's necessarily an association with how active these people are, and then what their result is as far as long COVID. I think there's something deeper than that.
Well, Dr. Williams, I think if you go, I was going to say, I'll let you kind of
I
start.
do have another one. Yes, indeed. Of course, it took until about October of 21 before Lancet published the relationship between severity of COVID and nutrition patterns. And it turns out that the people who were doing a plant-based or Mediterranean diet did so much better than the keto people, et cetera. And that's basically the microbiome that you mentioned. But you're really talking about the virus affecting the microbiome, and whereas they were talking about the reverse, that is, the better your microbiome from plant-based nutrition, for example, 73% decrease in moderate to severe COVID illness. But I don't know that anyone has done a dietary or nutrition analysis of people who developed long COVID. One would imagine if you're going to have more cytokine storm with a poor diet, that it would affect how many people would have long COVID, just like the virus made it, or the vaccine made it a little better. Have you seen any data that I haven't come across, or have made any observations about the worse your diet, the more likely you are to end up with a long-term outcome that's not good?
I haven't seen any data. I don't know if I could make any anecdotal correlations necessarily either, based on what I've seen.
All right, we'll have to work together, send you a nice nutrition survey and see if there's any relationship at all.
Sure.
All right.
All
Okay.
right. Well, I guess, Dr. We have before we go, and thank you, Dr. Foote, for an outstanding presentation. It was very timely and very pertinent, and we really do appreciate it. And one thing, we have a little tradition here at the University of Louisville for our guest speakers for Department of Grand Rounds. We have a little gift for our guest speakers, and this is a little tradition that's gone on almost 10 years now. And we have our gift is something that's very synonymous with the city of Louisville. And so we're going to be sending you your very own personalized Louisville Slugger bat.
Oh, cool.
Yeah. So help the Reds. I know they had a rough weekend in Atlanta, but at least they had a better start this year than last year. So,
Yeah.
so thank you. And Dr. Williams, do you have any final words, or?
Well, just really appreciate all of the insights, and we look forward to working together and see if we can't come up with more data on the issue that we talked about. And looking forward to doing the Cardinal Minute with you in just a few. So, Jason, you want to get sort of end it and then restart it? And we'll get
All right.
going.
Yeah. And all right.